currently work at the James Cook University Hospital in Middlesbrough. So I work in the medical physics department there. I'm a trainee clinical scientist. So again, I'll talk a bit about that as I go through the slides. So I'm a chartered engineer member of the BCS, and I'm also a member of the Institute of Physics and Engineering Medicine, so IPEM. So IPEM is the sort of professional body for medical physics and clinical engineering in the NHS and in academia. Back in 2011, I graduated with a BSc in Computing and Networks at Teesside University. And then after that, I spent a couple of years just in general IT. I worked in a Cleveland Fire Brigade's IT department and the school's IT department there. And then I applied for a job in the NHS to become a clinical technologist in radiotherapy computing. And that was completely new to me. I never heard of what a clinical technologist or clinical scientists do. So hopefully as I go through these slides, on this talk, it'll become a bit clearer. While I was working at James Cook, I managed to do a master's by research in computer science. So I focused on human-computer interaction. So it was fully research driven. I researched some medical infrastructure software and why it wasn't used by healthcare professionals, despite being developed by other healthcare professionals. And now, as a trainee clinical scientist, I work at the intersection of healthcare science, computer science, and medicine. And we get to provide technical solutions to clinical problems and also perform physiological measurements on patients. So that's just a quick introduction to me, but hopefully it'll become more clear as I go through. There you go. So what is a clinical scientist? So yeah, it's a good question. A lot of people probably not really heard of this. And like I said, I didn't. So according to the Healthcare and Professions Council, that's the HCPC, a clinical scientist is a statutory registered healthcare professional who advises doctors on tests, interprets results, and performs research to understand disease. So this is a very broad title. But in reality, they are medical physicists. So if a lot of hospitals have radiotherapy centres and radiology departments, all these are driven by medical physicists in the background. So they're all clinical scientists. They involve things like treatment planning, radiation safety, commissioning the radiation devices, making sure they're safe to use, making sure patients don't get too much dose, and investigating overdoses. There are physiologists in cardiac physiology, neurophysiology, and sleep physiology who are registered as clinical scientists. There's scientists in biochemistry, virology, microbiology who are clinical scientists. And there are biomedical scientists, which are a separate profession in their own right, but they can progress to become clinical scientists. And there are rehab engineers and clinical engineers developing medical devices as clinical scientists. But I'll put in bold clinical computer scientists, because clinical computer scientists can also become clinical scientists. So just a bit about clinical scientific computing before we go a bit further. So it's an area of healthcare science that is responsible for developing and improving methods for acquiring, storing, organizing, and analyzing biological data that supports the delivery of patient care. So when you immediately think this, a lot of people think of genomics and genetics. There are disciplines of genomics and genetics which do use computing, but when we say biological data, we mean everything like in physics, so cancer, everywhere, physiological measurement, studying the processes of the human body. So up until recently, this was called clinical bioinformatics. It recently changed its name to clinical scientific computing, the specialism, which I think is really good because nobody really knew what clinical bioinformatics was. That was a lot of people. If you go to a university, a university, and speak to computer science students that say, "Why don't you do the route in clinical bioinformatics?" They'll immediately think, "Oh, do you mean like working in genomics and collecting all that data and looking at DNA?" but that wasn't the case. It's more about the physical sciences, which were underrepresented. So the name has been changed to clinical scientific computing. And that involves software development, networking topologies, database design. So just like normal IT, really, just another word for IT. Responsible for ensuring compliance to IT standards and best practice for approving computer related interfaces for clinical use. So this is where the clinical scientist part comes into it, is the regulatory side of it and the standards and making sure everything's at a good standard. It bridges the gap between trust IT, so hospital IT departments, and specialist clinical scientists. So, for example, those medical physicists who are clinical scientists who run cancer systems, who look after radiotherapy IT infrastructure, you would work with them because they'd have the specialist physics skills and also have an awareness of the computing skills, but you'd be the go-between between the two staff groups because you'd know a lot about the computing and the IT stuff and a little bit about the physics to get by and to join them together. So I always say it's sort of like bridging the gap. Research is a big area, so a lot of research goes into AI, machine learning, big data, computer vision, VR, HCI, just all the general computer science topics, but applied to healthcare. So that's what the specialism is, and that's what a clinical scientist in clinical scientific computing would do. So the moral of what I'm trying to say is computer scientists can become registered as clinical scientists with the HCPC and become state registered computer scientists and work directly with patients and doctors to improve care. Now, this is what I'm doing. So you've got clinical scientists by the HCPC, you've got a clinical scientific computing specialism that's recognized by the HCPC for clinical scientists, and you've got computer scientists who study it to begin with. So put the three together, there's a career there in clinical scientific computing in the NHS. So this is just a bit of an infographic just to sort of summarize what I've said about clinical computing in the context of a project. You can sort of see here, I don't know whether you can see my screen, but in the middle, you've got the clinical computer scientists right in the middle, the domain-specific clinical scientists and hospital IT departments. And the idea is that, the clinical computer scientists can understand both sides of stuff and really work as a multidisciplinary team. So this is a big question that I always ask. Where are the actual computer scientists doing this computer science route into state registration? And I just think it's because it's relatively unknown. So I was saying to Johan earlier on, if you study physics at university, you'll do a module on medical physics, and then that's you're introduced to the world of medical physics and clinical science in that context. If you do electronic engineering, you may pick a module in medical electronics. Then you hear about the world from that module at university. But in computer science, you don't do medical computing or clinical computing modules, so you never really hear about this. So at the moment, we find that the traditional engineers and the physicists appear to be applying for these roles. And this isn't to say it's wrong. I mean, computer science is not a limited domain. It's not a gatekeeping area. But I do think computer scientists are taught computer science at university, so are better qualified to practice computing in the NHS. The good news is there appears to be some work to professionalise informatics and computing. There is the Fed IP. I've mentioned this quite a few times, but again, the clinical scientist route exists already for computer scientists. And you get straight onto the HCPC register after you've done the training program, which I'll talk a little bit more about. And then you find that it does grant more respect in the environment because you're talking to a doctor and they say, oh, you're HCPC registered. Oh, and you know this as well. And they're like, oh, yeah, we'll go to you. So it's a really trusted and respected position to be in. And also it's really recognized. It does regulate those physiotherapists and all those different healthcare professions. But I think that's a bit of a catch-22 as well. So when you say to somebody from our background, why don't you go for HCPC registration? they immediately think is, well, I'm not a healthcare professional, I'm not a paramedic, I'm not a physiotherapist. They don't realize that you can become one as a computer scientist, but I'm hopeful that by promoting awareness, this will slowly gain momentum. So the next question is, why should I become one? And do you really need to become one? Because you can work in IT departments and do similar stuff in hospitals, but you don't have to be registered. There's no law. There is no special law that says that you have to be a registered clinical scientist to do computing in the NHS. So, as I said, you don't have to, but you are given more responsibility, trust, and respect. And the advantage is you also get to be exposed to the deeper work of other specialisms. So a really good example is myself working in medical physics. I've been able to learn some of the physics and understand the work of them to really apply the computer science to help them solve problems in their domains. And it is also true when you're developing medical devices inside the NHS. So the medical device regulations have an annex in it that lets you build medical devices inside the hospital and use them in the hospital without having to have them CE marked. What we do normally find is that a lot of clinical scientists are really heavily involved in building these medical devices. So you've got specialist clinical engineering departments, not medical asset management, but the actual clinical engineering departments who are building medical devices. A lot of them are from physics backgrounds and engineering backgrounds, and they're developing these devices and building the software. And I always say, well, why not the computer scientists building the software too, and looking at the data, building the algorithms, looking at machine learning, looking at all the theory behind it all to really build clinical decision support systems. But the good thing about clinical scientists as well is that you get to build these devices and use the devices on the patients, and the results that the devices produce you can advise the doctors on. So it's a very unique profession, and not many professions let you do that. But I think one of the more important areas is that a lot of computing is well regulated already. So the example that I used was the medical device regulations. That's a really well regulated area, but I'll go on to that in a second. So one area that's very regulated is the radiotherapy and radiology. So the IT infrastructure behind radiotherapy is well regulated. Installing treatment planning systems that plan radiation treatments, very well regulated area. Anything to do with ionizing radiation for medical exposure, that's X-rays, radiotherapy, anything along those lines, very well regulated. So because of that, there's laws that says that a special type of person, a medical physics expert, must be involved in all the decisions, equipment, and commissioning of equipment that involves radiation. So there's a sort of slight problem, not a problem, but an opportunity to be made here. So there's a scenario that I can imagine is a medical physics expert who can legally develop software, then commission that software without the advice of anybody with a computing background or any knowledge of HCI, or anybody who knows about SQL injection, or how to write languages in a certain way. They can use that, go ahead and improve it and start using it on a patient. But what happens when it does have that SQL injection? That changes the radiation dose. At the moment, there's obviously it's all not being tested in law. So, but there is very little in the way of frameworks for computer scientists at the moment to do that. So if you're thinking about you working outside and you're trying to solve these problems, you're working in the IT department again, you're trying to solve these problems with radiotherapy systems, you're only then to find that you can't be involved because you're not really an MPE. So it's not really, it's not for you to sort of approve. There'd be interesting. I think that creates some interesting problems. However, if you become registered as a clinical scientist, it's quite so clinical scientists are really well recognized in those the regulated areas. They're happy to involve you. So I think that goes back to that trust and recognition and responsibility. So going back to the medical devices and software. So creating medical device software is a very regulated area as well with the medical device regulations. There's provisions in legislations that allow hospitals to build and use their own medical devices in the same hospital. So that's as long as you don't give it away to anybody else, you can build it and use it. And it's common to find clinical scientists developing medical device software and using it. And this is where I think computer scientists can really make a big difference as clinical scientists, is the being heavily involved in the good design device. So my master's project focused around redesigning a piece of software that wasn't being used properly. And it was really simple concepts such as just observations, sitting and watching the other staff groups use it. But these are sort of like common sense to us, but to those who are not in the area, they don't really think about that. So they just go ahead and design the software and push it out. But by becoming a registered clinical scientist, you're very able to get involved in all of this software that's designed, and as I say, they're really happy to involve you. And just another thing, clinical scientists, they build software, they use the software, interpret the results. Physicists and engineers are doing this as clinical scientists, so why not computer scientists? But we can do it. So that's a bit of a really whistle-stop tour of what the clinical scientist in computing is. I'm going to talk a bit about me now, so hopefully it'll put some context into it all. So how do you become a clinical scientist? So for me, at the moment, I'm training through this scheme called Route 2 with IPEM. So the specialty that I've selected and where I work in is physiological measurement, clinical engineering, and computing. So the physiological measurement and clinical engineering is what I'm learning. The computing is the stuff that I'm applying because I already know it, which is really good. So this route is a portfolio route. So I get to work with some senior clinical scientists who can guide me on the anatomy, the physiology, how to interpret the signals, what the signals mean, and help build software around that and medical devices around that and use it as well. So that's the route that I'm taking. I create a portfolio, I'll send it to the Association of Clinical Scientists, and they'll assess you for registration. That's one of the oldest routes that are out there. But the new route, which is the route which graduates should take if you haven't done a master's degree, is the scientist training programme. Now, this is a nationally recognised scheme by the NHS. So it's in NHS England, it's in NHS Scotland. It's a little bit more centralised in Scotland. This pays trainees at Band 6 in the NHS. And while they're doing it over the 3 years, they earn a master's degree in clinical science. And once they've passed the exams and done the degree, they'll do an exit exam, and then they'll be given a place on it. They'll be admitted to the HCPC register. So this is an established training program. You can look up the modules just by searching the STP clinical computing modules on Google, and they'll appear on Health Education England. I think the same modules for NHS Scotland. They're all pretty much the same. And then after registration, you can then become a consultant clinical scientist, which is the next step, which is supposed to be equivalent to the medical consultants. And that's a 5-year workplace. So you get registered first, you spend a couple of years working as a clinical scientist, and then a few years later, you'll say, right, I want to train to become a consultant clinical scientist, because they're the sort of senior roles. And this is achieved by the Higher Specialist Scientific Training Programme, the HSST. This is a 5-year workplace doctoral training programme, and it's fully funded by Health Education England. Same in Scotland. It provides equivalents to medical consultant, and you earn a DClinSci, so Doctor of Clinical Science, and a place on the HSSR for these consultant clinical scientist posts. And there is one for computing. So the program is called Clinical and Scientific Computing. So this is the same thing. You've gone in as a clinical scientist, and you can now become a clinical scientist, a consultant clinical scientist, and you're regarded as the expert in the expert healthcare scientist in your area. So you'll be an expert in scientific computing. And I think that's a really interesting route. And it's all fully funded, all paid for by your trust. And then it opens up those doors. And you tend to find these are heads of department, so heads of clinical computing jobs. So if you wanted to go for these jobs in, in the future, the HSST will be that sort of level to lead the clinical computing sections. So a little bit about a day in the life of me, basically. I'll go through that. Hopefully it will help with some of the other slides, because the other slides are a bit full to take in, because there's a lot of weird and wonderful terms. So what I do, physiological measurement. So I've mentioned physiological measurement a few times. So this is what it actually involves. So we do overnight sleep oximetry. So you can see there the wristwatch with the SATS probe on. So this is SpO2, measuring oxygen. This is a lot of people are more aware of SpO2 now, especially because of COVID. People are aware of their oxygen levels and what normal is and what isn't normal now. But we do this to look for sleep disordered breathing and sleep apnea. So we hand these devices out, patient wears them for 2 nights, brings them back, we download the results. Myself and my colleague, so while I'm a trainee, he's registered, my registered colleague, I work under his supervision. What we will do is we would review the results, and then we triage the urgent ones. So we think the patients who we think have got a really urgent sleep disorder breathing, we triage them from the consultants. And then we also develop the technology around this. One example is I'm working on the actual the database to store all these results, and eventually all the data what we hold, we can start mining that and learning from it. So that's a case of like using the technology skills and using the clinical skills to understand what's going on with the patient to build the technology. Another thing that we do is spinal cord monitoring. So this is a purely clinical one. So we're up in theatre. This is I always say this is really surreal from somebody like myself, my own background. We go up to theatre, surgeon. So we usually these are for children who have scoliosis, so they've got a curvature of the spine. So they'll go into theatre to have the spine straightened up. So they'll have some screws put into the spine and rails to straighten them up. What we do is we use our knowledge of signals processing to make sure that the patient doesn't lose signals to the lower limbs. And this is to detect an injury to the spinal cord that could paralyze the patient. So in the olden days, they used to just wake them up and ask them to wriggle their feet and say, move your feet. If you can move your feet, then that's fine. And then send them back to sleep. If you imagine, 12, 13, 14-year-old, 15-year-old children being woken up in theatre, asked to wriggle their feet, with the spine pretty much cut open, it's quite horrifying for them. So some of them wouldn't actually just stand up out of panic so we now have tools to do that with just signals processing, where we insert the electrodes and we monitor the spine. So we're heavily involved in that, and we get to produce the results and send them off to the consultant. Another big area is brain pressure monitoring. So you can see here, this device is an example of a device that we've actually built at the hospital. So this is a custom-made piece of equipment. The software is written in Python. The hardware is Arduino. So the handset connects to an Arduino board. The transducer connects to an Arduino board. We have an accelerometer that connects to an Arduino board, collects all of the data that we want from it. So with this, we take it up to theatre. Surgeon drills the hole through the head, puts the transducer into the brain. We connect it all up, check that it's working, take it to the ward, connect it back up to the patient after they've recovered. And then we record the data for between 24 and 72 hours, bring it back down, download the results, and let the consultant know what we think about the pressure, whether it's high or low, and we give them all the information around that. That is a really good example of something that we've built, we use, and we interpret the results and advise the doctor on the full process. And that's truly a unique position to be in. So that's why I'm an advocate of the computing careers. So, but we also do a bit of research for this. So very recently, it was actually only a few weeks ago, it's quite hot off the press, we used this device to find a pulse in a bone for a surgeon who was working on a bone and straightening a bone to make sure that the blood vessel didn't sever inside the bone and kill the bone. So he put the transducer in and you could see the waveform, and you could see the pulse, and that was pretty cool. And that was just something we're going to work on building further up. So I've talked about the clinical physiological stuff that we do, where we have to really understand the clinical side of stuff. The other side of what we do is development. So this is an example. This is from a master's actually, of an app that I designed for managing machine log faults. The old system required radiographers to sit in front of a desktop application to log faults, and it just wasn't getting used. I mean, you can imagine radiographers, helping patients into the room, getting them all set up for the scans, getting them all set up for the treatment, and then managing the systems around that. And something goes wrong, they don't have time to log the faults. So I've created a new system around that, and it's just basically just an Android app. You can see an example there. More development. This is a pretty cool one. So we're heavily involved now in 3D printing of bones. So previously, what used to happen is, so the patient would go for the scan, CT. So they've got a really badly broken bone. Go for the CT scan, and then they'll think, oh, we'll download the bone. We want to make a bone. So they'll put it on a CD. They'll burn it to a CD because the imaging system would only let them do it on a CD. Where we got involved was we installed very simply an open source DICOM server. Now, so if you haven't heard of DICOM is just the standard file format for medical images. So if you go for a CT scan, an X-ray treatment that involves radiation, or any medical ultrasound, it all saves the file as a DICOM file. It's just a special type of file that all these systems can understand. But they used to burn it to a disk, so we just created a DICOM server, and the imaging server now pushes it straight to the DICOM server that dumps it in a folder that we can just drag into our 3D software for modeling the bone. I mean, it's those common sense things where I think, you think somebody from a computing background will be like, I'm sure that can be done by a server. It doesn't have to be done by a disk. You can make that fully electronic, and that's what we did. But on top of that, now what we do is we also 3D print the bone. So this is a model that I made from a bone. So we took the scan, put it into the software, plan the bone, and then print it on a 3D printer, and then hand it over to the orthopedic surgeon for planning surgery. And recently, I managed to go up to theatre to see the surgeon actually use the bone that I printed to plan moving to resetting a bone on a child hip. So that was fascinating. So IT, this honestly just general IT stuff that we do as well. So this is just a backup solution, backup exec. I would have used something like VM or something a lot better, but they wouldn't give us the money for it. So NHS is always a bit strapped for cash. But this is what we did. So before I started my role, there was no backups in place. So I spec'd up a backup system, we procured it, and now we've got a full backup system to back up some critical data for treatment planning systems that didn't really exist. And there's plenty of other little IT tasks that we do. And I must say, this is all away from the main hospital IT department. So this backup system is for radiotherapy. And because radiotherapy is really regulated, the clinical scientists take accountability for it. And we find that hospital IT departments sometimes don't want to take that accountability, but to assure the accountability, they manage it themselves. Again, this is because of the ionizing radiation regulations around operators and stuff. You have to be an operator if you're involved in radiation, and all these legal definitions. So you tend to find radiotherapy departments have their own IT infrastructure in place. Leeds is a good example. Leeds has a massive data center with HPE Nimbles. We've got HP DL380 Gen 10s, I think, or whatever the latest ones are now. they're looking after all their own infrastructure there. The same thing for us. We've got HP Nimbles ourselves. We've got DL380 servers. We've got Hyper-V clusters. So we're looking after our own IT equipment inside the hospital network, but we don't work in the IT department. So we do feel a bit like a shadow IT department, but we're just as equally as qualified. You know, a lot of the people who are working in the IT section now are from IT backgrounds. They're just as qualified as somebody working in the IT department. So I'm hoping that was okay, not too like what's all these weird and wonderful terms. But if there's any questions, I'm happy to take lots of questions about them now. Hopefully clarify anything that was not clear. Stop sharing my screen now.
So at the moment, everyone's no one is able to unmute themselves, but I will set it so that people can. So actually, let's do if you've got a question, could you use there's a reaction, so you can like raise your hand so we don't have everyone at the same time asking questions. If you have any questions, might be a good way to manage it, perhaps. Or do we no, let's do it free for all. Let's if you have any questions, feel free to unmute yourselves. I've made that option available now.
So can I just give a comment? I really welcome this. I've been involved in teaching computing since about 1960, and before that I was involved a lot, and have been over the time, with bioinformatics people whom you mentioned. And I've always thought one of the most satisfying things about computing is that you can really get to know people in another speciality. So I really welcome, training and development in the way Andrew has described, because I think it's very satisfying. I think it gives respect. It's really pleasing to hear that somebody has thought through a career path, encouraging people. I'm very grateful to you and Andrew for organising this.
Oh, thank you, Peter. Yeah, it's definitely really interesting. As you say, computing is a subject where you can work with anybody to solve their technical problems, but we're just as capable as learning the work as a lot of other specialists are as well. So, and I think that's where they've finally identified the gap, is that if we get people computing backgrounds into the NHS, they can work with the other areas like in pathology, medical physics, cardiac physiology. I forgot to mention, but a really good example is I've just done an advanced ECG interpretation course as well, so I can interpret ECGs, show the heart traces. So eventually I'll be able to build systems around them, and and that's if they, by giving us the tools to learn the work of the clinical context, we can apply our knowledge as well, just as the physicists do, just as So, but yeah, it's definitely an exciting area. Hopefully, more people do it. I'll also paste the link as well.
Are there any other questions? Do you want to say it again?
What I'll do is I'll paste the link in the chat box as well to the actual clinical scientific STP, the scientist training program. So if there are any academics here, lecturers who want to promote it to their university students, the link, they can pass them on this information. I'll paste that here.
Could you add it to the presentation, and then maybe we could put the presentation up with the recording?
Oh, definitely, yeah, will do. Yeah, I'll add it on to the end of it. Yeah. So, but this is the thing for me. As I was saying, I wish I heard about this while I was at university doing my undergrad, because I would have gone straight into it a lot sooner. Although it only really came around in 2014, the computing specialism, to get into it. So, but I'm hoping that just like they do in the other degrees like physics, that they'll start pushing this and say, oh, this opportunity is there, and we'll see more people coming through it. And I think as more people go through it, there's a huge workforce there of people who understand computing and can learn the work of the others.
Excellent. Are there any other questions from? We actually have a grand total of 15 people in the talk, which is great. It's a great turnout.
I hope it was useful.
By the sounds of it, I found it really interesting. I think it's I found particularly like the medical devices aspect. I found that to be really interesting. You know, the fact that essentially consumer devices like Arduinos can be used within, you know, real medical devices doing really cool, innovative, you know, cutting edge medical device research is fascinating.
Yeah, I forgot. I was going to say about the so that was in the ICP monitor where we used the Arduino to get the transducer signal. So I do some research with Glasgow at the moment. Well, I'm looking into doing some research with Glasgow around artifact detection. What is artifact in movement in the ICP? So, but it's one of those things where we've built the technology, we generate the data, and then we can look at the data as well and really and start using that data to inform clinical practice later on. You know, like for example, with the artifact detection, help understand what is artifact and what isn't artifact. What bits are important to look at when you're monitoring ICP, and informing that practice later on is really, I think it's just a fascinating position to be in.
Yeah, I mean, I think the entire area it's just really cool. What do you think about like edge kind of edge IoT within the medical devices? Is that something that you see kind of growing over time? You know, like having essentially machine learning on your hip, because it's going to help you detect when.
Yes, definitely. So it's I should have mentioned. So there are some projects that I'm working on, but it's quite, you know, they're all like intellectual property. You know, you have to be careful what you say. But I think edge and wearables, IoT is going to be a massive thing. And I'm actually working on a few IoT projects at the moment that get information about certain things from patients to really build that picture up about them. So yeah, it's a huge area. And again, that's another thing about, you know, as a clinical scientist. So I'm actually developing the equipment now. So the Bluetooth, you know, the Bluetooth device, the mobile application, I'm developing it now. I'll be able to use it on the wards to do what I need to do, and I'll have that data to look into and research. And then, you know, I can, and you know, with learning the machine learning and, you know, the algorithms behind it, I can apply that to the actual data and do everything. We do everything there in one area.
I just think that's cool. There's no other way for it. Like I can't describe it in any.
That's true. It is pretty cool. As I say, it is really interesting to be able to build it, use it, and go up to the patient and say, "Oh, hi there. I'm just going to plug this onto you. You know, if that's okay." And, you know, get the data and then use it all. It is fascinating.
Excellent. Unless there are any more questions, if you want to pop them in the chat, if you want to unmute yourself, you can feel free to do so. Otherwise, we will let Andrew get on with his evening. And the same to everyone else. I wish you all a great Burns night. And yeah, thank you very much, Andrew. It's been a great talk. I'll coordinate with you around slides and everything like that. And once we get the links for the video, we'll send everything out.
Oh, brilliant. Thanks for inviting me as well, Joanne. And thanks very much as well, everybody, for coming along. Hope you found it interesting.
Thanks. Yeah, thanks very much. It was very interesting, very clear. That's why you got so few questions. Very clear what you were talking about. Thank you.
Oh, thanks very much, Norman. Thank you.
Thank you very much.